This will be live streamed and recorded on YouTube on the DSS YouTube channel, just as a reminder to everybody. Let me turn the audio off so I don't hear that in the background as we're doing this. Okay, well, welcome. Lovely to see everyone. I suspect we'll have a few more individuals popping in. So I know I haven't convened in a little bit, and it is nice to see everyone. Hopefully everyone had an okay Thanksgiving. So today we'll be running through some slides. We'll kind of go through a few different things. Here's our agenda for the day. Susan and I will be kind of running this. Commissioner Gifford is here, and I know she may want to say a few words at the top, and we'll be with us for a few minutes. And then the other guest we have, Deepti Kanaganti from OHS, the Office of Health Strategy. She's one of the consultants from Baylor that's joining us. We have something relevant that she'll be helping with related to this towards the end of the meeting. So we'll be turning to her, but she's joining us for today. Commissioner, I'll turn it over to you if you wanted to say anything briefly at the top.
Thanks, Brad, and good afternoon, everyone. I just wanted to say hello and say again, thank you for your ongoing participation in this really important work for DSS. I know the team has made progress, and we continue to look forward to making further progress. I think that your work in advising us here has become more salient as things have progressed, and we've sort of begun to continue to understand the adverse impacts of the pandemic. We're also, going to be seeing changes to the Medicaid program as we transition out, hopefully someday, of the public health emergency and begin to sort of scale back the enhanced eligibility or limits on disenrollment that have been in place since the beginning of the pandemic. So that's an important variation on our work. And then also the OHS primary care work and quality benchmarks has a lot of intersection with your work. And we wanted to make sure that you were fully apprised and that body and you are taking into account each other's work as we move forward. So I will be in the background listening and learning from all of you, but I did want to say thank you again for your time and your expertise, and it's valued by us at the department. Over to you, Brad.
Thanks, Commissioner. Yeah, definitely second that. Really appreciate it, and glad we actually have 2 meetings on the book in the next couple of weeks, which I think we'll be able to make relatively, good use of. So we'll be kind of moving along. And actually, Susan, let me just ask if there's anything else you wanted to add at the top. I know Susan has some great things to share a little bit later, but just wanted to see if there's anything else you wanted to open with.
No, just want to welcome everyone and share sentiments that it's nice to see everyone again, and hope everyone had a nice holiday, and look forward to chatting more today about how we can move some of this work forward.
Thanks, Susan. So just start updates on status of the transparency work and where we are, and just to try to be transparent about where we are in the process at this time. So kind of our team leads internally include myself, Susan Smith, and Krithika Diva, who's was not able to join us today, but hopefully will be joining us further as kind of our technical expert. We've been spending, Susan, Krithika and I have been spending a lot of time together, and I think hopefully moving things forward, and we'll kind of explain where we are in this process and some of our own internal processes to make this a reality. So just to kind of update you on in terms of data, because I know, one of the things that as a board previously we had set are a lot of requests or a lot of aspirational data measures that we want to display publicly. And so I think what we've had to do is figure out even some of our first baby steps to making some of this a reality on an ongoing basis. And one is just figuring out how we're going to have the data to display. So internally at DSS, thinking about one, the quality measures component, the eligibility data, and then the fiscal data. So in terms of quality measures, so internally at DSS, we have our data warehouse as well as the MMIS, both storing immense amount of information. Internally, we don't really have a lot of manipulation of that on the back end. We have some, but it's not formatted necessarily for ease of visualization through like a Tableau public-facing web portal at this point in time. Eligibility impact. So that's, we're actually working on a dynamic dashboard for that. Susan and her team and Kritika have been actively working on this. And then for fiscal, we do have this in the data warehouse as well as in Core CT. And that's just awaiting some updated data, but we will be able to, that's pretty much easier for us to internally turn out to be publicly facing, if that makes. So again, sitting inside kind of the DSS four walls is kind of these three core sets of data. Again, the quality measures is probably the most challenging for us to execute on at the moment, and we'll kind of talk a little bit more about that. The eligibility and fiscal data is easier just because of how the data is stored and also our in the format that it's in. In terms of external, kind of quote unquote external to us, but very close related, are ASO contractors who we work very closely with and are really are instrumental in our operations. Those include CHNCT, Medicare, Beacon, and VEO. They receive data files on an ongoing basis, the ASO data files. They receive it in a pre-specified manner that they then, on their end, will massage or manipulate the data so that it becomes actionable, and then they're turning it into meaningful information that they actually produce dashboards for at this point in time. Those are non-publicly facing dashboards, but they use it. Susan, Kritika, and I have been meeting, talking with them about it, looking at it, kind of trying to figure out how do we take what they're doing and then actually help DSS facilitate this on our end. And just wanted to throw it out, if anyone wants to make any questions or comments, you should feel free to raise your hand along the way. This is, I think we welcome your input and expertise. So again, if there's anything you even wanted to say or ask along the way, if there's something's not clear, please do. And so we've been meeting pretty regularly with the various heads of the ASOs to get a better handle on how can we work in initial partnership, recognizing that, especially for the quality measure component, internally, we have, again, this really unformatted data that is not ready to be produced for public consumption. And the ASOs who are receiving the data from us are actually producing this in a meaningful way already. External to that, I know we've talked a lot about how do we get access to data from other state entities and other places that we're interested in presenting. And so we are currently working on creating a master data use agreement with a sister agency so that we can hopefully use that as kind of an opportunity to learn how to most effectively get data sharing between various state entities that we can then hopefully collaborate on and produce publicly some of this information. I'll pause for a second. Susan, anything else you want to add on any of this? Okay. And any questions from the group? Again, if there's anything, we can always come back to this. So we're undertaking some internal process steps to try to kind of move things forward, and I'll just walk through some of this just to update everybody and so where things stand. So after meeting kind of multiple times with our various ASO partners, we identified that really, so again, we're sending them this file of all the data. They're taking it, manipulating it in a way so that it can be visualized and have meaning from it. But one of the challenges we recognize is each of them might be making slightly different decisions about how that data is being changed on the back end. Which means that, if we ask one ASO to run the data, it might look different from the other one, which is a challenge if we're going to publicly report this out, because if that, doesn't look great if you have slightly different outcome, something for X is Y when this ASO produces it and it's Z when it's other one. Well, we want to be very clear and also transparent about how we're producing this information and have a single source of truth for it in the long run. So in the interim, we are working to identify specific measures that we're going to ask the ASOs to help produce in a static fashion, not dynamic, which I know is ultimately the goal for us, that we can at least publicly display some information that is useful. And we'll kind of give you an example of what this is going to look like in a little bit. So that's really where we're still kind of early on. We had explored trying to have the various ASOs actually send data back to us. There's some challenges with us receiving that and then being able to do it. And ultimately, I think as we discussed, we would like to be able to do this kind of internally at DSS within the four walls so that we can have it. So we're not necessarily sending it out and then sending it back. It seems like this is work we can do, though we have to develop a team to do it. So we're kind of along that line. The next step is to kind of preparing these low-hanging internal data sets on eligibility and the fiscal or financial data. So this will be a good exercise in our half to have this information from internally publicly facing. And so that's currently being worked on. And then we're also having to develop a bit of a larger team or think about how we're going to have a team of individuals work on this. Because as you can imagine, the amount of effort to do this is not inconsequential to actually get this off the ground. So that is also part of this work, is so that we can develop the capacity to produce and manipulate it on our own. And then the other one is getting better measurement specs and coding. So for those measurement experts in the audience, we obviously need to understand very clearly how the ASOs are currently doing this. And we know this for some of the measures is very clear, but we want to understand the back-end coding. So like which CPT codes go into this measure and what are we including and excluding, so that we can make sure that as we're producing this information, we can answer questions as they come up, and also just provide that information so that we can be transparent about it as well. And then the other piece is the data infrastructure development that we just mentioned, that we need to integrate numerous databases so that you can have this cross-sector analysis between these different components, which right now, most of these things are isolated. If we want to pull even the fiscal and some of the clinical quality data together, we're not going to be able to do that right off the bat. It's going to take some time to be able to integrate that information. And there is this open question that I mentioned about, that I put here about a data feed from the ASOs, which we have discussed and is still open, though I think that is to be determined whether that actually makes sense or not. So hopefully I'm trying to, I think as part of this transparency process, be as transparent as we can in terms of where we are and how this process is operating, just to give you all of behind the scenes, and also get your feedback if you have thoughts about how we can do this more effectively. Jim.
Thanks, Brad. If I'm understanding this correctly, you would have each of the ASOs essentially submit that data back to the state. Is that correct?
If we went with the interim step process, we may not do that. So right now, our kind of phase, and we'll come to this, is really just getting static kind of data to present rather than having us send the actual data. Though we've explored having them send it to us as well. But there's some challenges with that, both because they're not necessarily producing it in such a format that is easy for them to send it. So it actually requires effort on their behalf to send it back to us to a degree. And it may not be worth the process of doing that for each of the individual ones, especially if we hope to do this on our end in the long run. Does that answer your question? Feel free to ask a follow-up if it's helpful.
Yeah, no, I think that makes sense. I think one of the challenges or considerations here is that, especially for Medicaid, as opposed to a more stable coverage like Medicare or some commercial coverage, there are inherent decisions that have to go into, how you make the quality measures and how you do the look backs and how much data you need in order for the quality measures to be valid. And those can change from place to place, right? Those are kind of inherently individual decisions. I wonder if there is some way, if we're going to have some interface with the ASOs, to dictate that process, as opposed to having data that comes from them that's a little bit different because some of the decisions that went into them are a little bit different. I think you're on mute better. Right.
Yep, definitely on mute. Thank you. But yeah, no, I think you raised really good points, and we obviously have opportunities to help craft some of this with our ASO partners in terms of what and how they're producing it, recognizing that these changes aren't not necessarily insignificant ones, but and are important parts of this process. Like how much of this are we doing internally, and how much of this are we applying on inside the four walls of DSS, and how much of this are we relying upon our external vendors to help us with this work that they've already been doing to a degree, but may not necessarily be exactly what we're looking for. But I think your point is very well taken. Susanna?
It's sort of a follow-on, and it's really just sort of understanding the difference, right? So among different kinds of measures, right? So when I try to remember what's on the proposed dashboard, I think that there's a mix of things that are probably already calculated, and we're thinking more about sort of how they're displayed or whether they can be stratified, versus things that are new, and of the new, some are relatively straightforward and some are probably less so. But for some things like HEDIS measures, and I can't remember if there's any HEDIS measures, nobody can calculate them, right? Because the ASOs calculate them, but they're using like a proprietary software. So there's less flexibility. But it does seem like some of the things we've thought about are going to be more straightforward and are newly calculated, but more straightforward to calculate. So I assume you guys are sort of essentially categorizing them, and maybe that's what's coming. So maybe I should let you sort of bring that forward. But some that are new may be actually easier than some of the traditional quality measures.
Yeah, and I'll just say actually HEDIS is one of the ones that obviously there's challenges because some of it is proprietary, but there's also HEDIS-like measures, as you kind of alluded to. And those are things that are already kind of being produced, which make it easier for us to ask for that information because there is a little bit more standardization around that rather than some of the quote unquote newer ones. And the question also becomes, do we want, if we're asking for a new measure that no one's producing currently, whether it's in-house or at the ASO, do we want that to be reduced at the ASO if we're ultimately going to be doing that in-house in the long run, if that makes sense. So I think what you'll see here as we kind of go through the kind of dashboard kind of example that Susan has really kind of started to curate is really thinking about what are the low-hanging fruit, and really HEDIS measures or HEDIS-like measures are probably ones that are, ones that people are familiar with, probably a low-hanging fruit area for us to be able to externally demonstrate or to display, even if it can't be the exact HEDIS measures because of the proprietary nature of it. But so it's a good question. And I think we won't necessarily go through today the measures. We're meeting again in 2 weeks. So that could be part of one of our follow-up items that when we meet at that time frame. So we'll show you what we have, and then you can feel free to ask more follow-up questions then, Susanna, if that's helpful.
Brad, the other thing I just throw into the mix, which I know you all have talked about over the course of your meetings, is that we are required to calculate and submit the adult and child core quality measure set to CMS, as well as the entire Transform Medicaid information system, the TMSIS data that has to go down to CMS. So we have, because of federal requirements, we have a set of measures that I believe many of those landed on your recommended list. So that there's a glide path to that process. And to your point, Susanna, about different types of measures, like the core quality measures, like those are on a glide path. And maybe we don't think it's totally perfect the way we're doing it, but it's definitely on a glide path. And then we have the other sort of standardized HEDIS type or NQF measures that are really well specced out. And then we have these more bespoke measures that you all have come up with that we want to do. So I think we're probably pretty far down the path on a good chunk, and not starting from scratch with the whole list.
Yeah, especially the core measures, just as the commissioner had said, I would say those ones, I was actually meeting with one of the DSS team members that helps put that together for CMS. And so just trying to figure out how do we make sure we're we're capturing that low hanging fruit and producing it publicly, because some of these, and again, I think this is where we will, and I think want to run through what is really easy and what's maybe even we think it might be easy, but there's some challenges, and we can identify what those challenges are. And I think it's worth spending some time probably at the next meeting talking through that exactly. Sorry, someone else want to add something? I froze for a second. I thought I heard something, but it might have been just a glitch. Okay. So we did meet with David Nkuso, Washington State. So some of you may be familiar with him, but he really helped spear a lot of the work around the Healthier Washington dashboard, which I think sets a good example of the kind of information we would like to use. They don't necessarily incorporate all of the information that we would be looking to. So I do think there's opportunities for us to kind of take it a few steps forward from what they're doing, but they definitely set a really nice, I think, benchmark of kind of what we might want to be producing in the long run. So if you haven't had a chance, I think we talked about it early on in our when we were meeting as a transparency board work. But if you haven't had a chance, feel free to take a look at it at your convenience. Again, I think it sets a nice standard for what we might want to be producing in the long run. But he was wonderful, really helpful. We were trying to understand kind of the behind the scenes, how they're doing it on an ongoing basis, because it's obviously there's there's the initial inertia energy to get this off the ground. And then what does it require in terms of maintenance to maintain this type of in the long run? And those are obviously related, but different questions. And so he was extremely generous with his time and information, and willing to circle back with us as well. And provided us some technical information about what kind of databases they're using, who's doing the coding on the back end, that type of information. So feel free to take a look here. And I think we'll probably be following up with him a little bit more for some further advice in their processes. I'm gonna, I think, shoot it over to Susan now to talk a little bit about the dashboard development process and where we stand here, to talk through kind of where this is headed and where we are now.
Thanks, Brad. So much of what Brad said is really kind of teeing us up for some of the work that's going to be happening related to the first iteration of the dashboard. We're looking at producing something that's static at this point, relying majorly on some of the data from the ASOs, but also obviously looking at internally available data that we can also include. I'm going to show you a little bit later, just an example of kind of some of the storyboarding that we've been doing with respect to some of the data that we've already gotten from the ASOs. Certainly not representative of all the data that we would necessarily get. As Brad mentioned, that we're looking at trying to get kind of core measures, standard things that we can get from each of them. But at this point, we had just started to unpack certain things that we could get, things that were already being developed, things that were of high quality. And so we just wanted to start to play around with how might we put this into a static dashboard format. What are the kinds of data that we'd want to include? So, certainly what we ultimately will end up with probably is not going to look exactly what you're going to see today, because obviously, in addition to getting additional information, we really want to think about kind of the narrative and the storytelling of it. So, we really were trying to unpack and see what are the kinds of information that potentially we could ask for or will have, and how do we want to potentially display that? So that's what today is really to start to share with you some of what we've gotten, some of the ways that we might want to present that information. We also will be working on and making sure that the data that we stand up and share has meta information. So obviously some things that help users to really understand what they're seeing. So we'll be paying really close attention to the labeling of the information, any guidance that folks will need. So that work is also going to need to happen in order to obviously make sure that folks are able to digest that information in a substantive way. We talked a little bit about kind of that exchange of potential raw data and us doing certain things with it. We have gotten for some folks some aggregations of data that we actually are looking at and playing with, so that we can think about different ways of visualizing those data, but also making sure that we really understand what those data represent, and are able to kind of use that to help think about best ways to represent those data, and also, again, as I said, the story of those data and some of the guidance. In addition to what also we may be getting from the ASOs, we will look to see if there's some ways that we can potentially also internally replicate those to kind of accelerate some of the second and third phases of this work to getting to that part of interactiveness, and so that dynamic and filtering piece of it. So we are kind of wanting to do some of this work perpendicularly to doing the static dashboard, so that we're not losing too much daylight with some of those pieces, so that we can move into more of a full-scale version of the dashboards. We're also thinking about this in relationship to other activities and other initiatives. Folks know that Public Act 2135 is requiring that state agencies are comporting to particular formats with respect to the collection and reporting of REL data, race, ethnicity, and language data. So we're thinking about the interaction of that work with this. So obviously thinking about the disaggregations and the ways that we're representing these data, trying to ensure that demographic information is standardly a part of the data that we're presenting, and what are some of the best ways to represent those kinds of data, what are the best ways to visualize some of those data, and thinking about obviously the quality of those data. So parallel to this are our internal efforts to look at some of our missing data and thinking about ways that we potentially can reduce some of that. Are there certain outreach and certain information that we can share to encourage folks to better share some of their REL information, but also, just making sure that some of the efforts that we're participating in with the new legislation that really is kind of at the core of improving the quality of REL data is very much a part of the work that we're doing with the dashboarding. And again, some of the representations of the data, I think, will help us to really surface some of those issues. So if we are making sure that we're presenting the data in really strong ways, that we are also including unknowns and missing data, that also is a way of being candid and transparent about any of the missing data and data quality issues, but also gives us a way of starting to benchmark any improvements in some of that data and the quality of those data. So I'll pause for a second if there are any questions at this point. All right. So I know this is very, very small, but I just put it in this format just so you could kind of see kind of some of the things that we have at present. I do have slightly bigger versions of these and subsequent slides. So these are actually created in Word, just because, again, these are static representations. So it's not easy to kind of really get them as large as one might want for this type of a format. As I said, I'll go over these, but as you may be able to see is that trying to provide information for some of the core categories of quality measures that we had talked about, behavioral health data, dental health data, medical data, and then some cost transparency. So again, this is not in any way representative of the total breadth of information, obviously, that we're going to have, or even necessarily the measures that we will start up with. But again, these were some of the data that were provided to us. And so I tried to take kind of a mixture of some of those data and kind of stitch it together to try to think about different representations and different kinds of information that we would want to share that would help to answer some of the questions that we have jointly identified. So I'll move over to the first representation. So this is behavioral health data that we received. This is actually related to a HEDIS measure pertaining to follow-up after hospitalization for mental illness. This is screenshots of the data that was sent over to us, which includes some nice national and regional comparison benchmarks, give some trend data, some performance from previous years, also disaggregates these data by different demographic groups, and provides some really nice contextual information and explication about what these data tell us and don't tell us, and opportunities for improvement. So I think that there's definitely some pieces here that I think we may want to try to pull through in other representations, and certainly the ability to disaggregate these data by various rel categories, I think is going to be essential. So we thought this was, I thought this was a nice representation of some of the ways that we might want to try to share and present these data. These are dental data. And as you can see here, there's also, it's a little, I know it's a little small, but at the top is a representation of CMS 416 data for children, which having to do with the receipt of preventative dental services. We also have information related to our national rankings, so very similar to some of the concept that we saw on the previous slide, and then other bar charts with other aspects of the receipt of dental care. So per payment per month. There's also a mystery shopper, outreach visits, in care coordination cases. So again, just trying to take different swaths of information that, again, depending on the nature of the service and depending on the nature of the measure, whether or not there are certain representations that we would want to get consistently from all the ASOs, and try to at least start with representing some of these particular pieces across all of them. And this is medical, as you can see, and this is more kind of descriptive, if you will. So this is membership data. So this is looking at membership data up the top by quarter, going over the past year or so. There's also representations of member representation broken out by key demographics, by program type, Husky B, C, and D, also by membership attribution, and then also at a geographic level. So again, some things here that I think would be great if we could, for example, have more, have geographic information available across various types, and then thinking about if there are other also, kind of trend information and what period of such trend information that we want to provide. So again, I think some good representations of the kinds of data and the visualization of some of these kinds of data that we may want to do across the various data types, depending on, obviously the nature of the measure that we're collecting. And last, this is actually, this is from the most recent OPM financial accountability report. So this is the Medicaid expenditures and caseload trends, and then also the Medicaid population proportion versus expenditures. So the enrollment versus expenditures, and then below some Medicaid growth trends. So again, not necessarily representative of all the data that we would present, particularly on the cost transparency side, that there are data pieces that I think we'll be able to produce internally, but I thought it would be helpful to potentially include some of these, at least in a consolidated place, to help us start to answer some of the questions that I think are related to the cost piece of the work that we discuss. So again, just a couple of visualizations to give you a sense of what how we're thinking about this, and some of the ways that we're thinking about representing these data in the static format at this point.
Thanks, Susan. So these are kind of what I think internally we're kind of working with in terms of our recommendations to our phase 1 approach, is really having a minimal viable product that includes static data from the ASOs around really mostly clinical quality measures. And then additionally, some static, potentially dynamic financial data, depending on what we're actually able to do. So that's a little up in the air. And then some dynamic eligibility data, which would be nice to have as a part of this, because I know ultimately we want to have all the data be dynamic and easily stratifiable. But I think for our realistically where we are, at least, is this kind of goal in the very near future, is being able to put something out in this and along those lines. Any comments or thoughts on this?
New comment, currently unmuted comment, Alt + A button.
Oops, sorry, Donna. Can you unmute again? I think you're.
New comment, currently unmuted.
Okay, let me try it again. Can you hear me now?
Yep.
Okay, I'm sorry about that. I have a question about the financial data. Would that be someone on Susan's team producing that, or somebody in the fiscal office, or are ASOs producing, potential utilization data?
Yeah, that's internal. That would be our own fiscal data from internal to DFS.
That's correct.
Mm-hmm. Will they work with the ASOs, given the issues and history we have with claims and claims run out processes?
I'm not sure we would initially. So it's a good question, but we obviously are sending all that information out. So it depends on what our faith.
I could share a cough drop.
Thank you.
Just went and got one.
I think it depends on how much we want to start with, and we'll probably start with the low-hanging fruit from the financial data, and then in the long run have more detailed information. So likely that would be probably part of a follow-up phase rather than phase one.
Okay, thank you.
Hi, Brad, it's Mark. I added a comment in the chat because it was kind of detailed, but
I
just
can't
want to make sure you saw that.
Did not. Do you want to say it out loud? Sorry, as I'm sharing, it's hard for me to see.
Yeah, it may not, also on the recording, it might not be in there. So yeah, it's just the Healthier Washington dashboard. It's like a similar approach to what Susan shared with counties, gender, age, race. I think that's very useful. I just wanted to note that the largest disparities are usually like sub-county level. So within, Hartford versus other towns, for example. So DPH currently disaggregates some of the healthcare access data by like the SBI score, which is like the low SCS zip codes versus all others. So I'd recommend, looking at that, or ideally something that has more than 2 categories, so you could clearly see the geographic disparities within the state that are they're really masked by the county level data. You could see that in the Washington dashboard as well.
Yeah, I think we definitely want to aim for that as much as we can. I think I know Susan's always like, we want to provide as much detail as we can without identifying Bob, I think is usually Susan's thing to say. So as much as we can to, protect individuals, but provide as much detail at a granular geographic area.
Yes, several initiatives use like a 5 Connecticut's, which is grouping the large cities, grouping the wealthy towns, for example. So you're not identifying a specific town even. Yeah. That can potentially be easier than, trying to have granular designations for everything.
Thank you. Yep, I agree.
Agreed. I think make sure you continue to tell us about that, Mark, as we move forward with this work, because we're not quite ready, I think, for that. I mean, we're ready for it, but I think we're realistically not ready to produce at that level at this point. And so that feedback, again, I think, as part of our initial process, realizing this is going to be an evolution over time, and your expertise and feedback in this process will be extremely important. So that level of commentary is extremely helpful for us as we continue to refine this and hopefully produce something that's, I think, hopefully we can be happy about, or at least most of us can. Any other comments or thoughts? So with that, we're actually going to pivot slightly to something that's not terribly familiar, likely to any of you. So I want to provide a little context for this. And Deethi will be helping me with some of this. But as you are probably all aware, we had an Executive Order 6, which created the Transparency Board, and now related to our ongoing transparency work with this, there is also Executive Order 5, which charged the Office of Health Strategy with setting quality benchmarks for both public and private payers. It charged multiple other things too, but that's just one of them, and that pertains directly to why this is coming up here. This also probably is information that will be useful for all of you who might be interested in this to hear about as well. And so as part of this process for setting these benchmarks, so there's measures that are determined to be set for the entire state. We'll get into that detail in a minute. The OHS Quality Council is charged with helping make recommendations to OHS on setting a target for the future. And so that includes Medicaid targets. And since you all are the DSS Transparency Council, very much related, that's very involved in helping us think about both transparency and also measurement. we wanted to ask for your input as well as as these quality benchmarks are set. And so this work is still ongoing at OHS within the Quality Council as it stands, and will be ongoing for the next month or so, at least in this benchmark setting process. But we want to bring these benchmarks the recommendations to this group to kind of be reviewed in light of kind of, again, your expertise and backgrounds, to one, provide any other recommendations or kind of say, yes, this makes sense from our expertise as well, which can then be brought back to OHS. So that's kind of the ask in this process, is for your expertise in helping. So we're just kind of previewing this. We're not really ready for you to provide any information. We'll likely be providing asking you for some feedback at our next meeting, but we're a little premature. So this is mostly a preview of that before we bring this back in a few weeks to you. Deethi, did I say anything incorrect, or do you want to modify anything I just said?
No, you've mentioned everything right so far.
Okay, good. Just wanted to make sure. And I know Kelly Sinko, who is or OHS, wasn't able to join today, but she sent lots of helpful information, and Deethi is a very knowledgeable person who drives a lot of this at OHS. So I'm very confident that she will be able to kind of walk us through this process. And I'll just make a note, I know we're talking about our dashboard at DSS, and maybe our slides aren't as beautiful as the OHS ones for now. So that's maybe something Susan and I have to work on. So we can have maybe a better representation as we're comparing to the OHS slides. So Deethi, let me turn it over to you, make some comments, walk us through this a little bit, if you don't mind.
Thank you, Brad. And thank you all of you for your time and letting us walk through the quality benchmarks and for your coming feedback at the next Transparency Council meeting. Before we delved into the weeds of the quality benchmarks, we really wanted to quickly provide an overview of Executive Order 5 so you could see how all of these initiatives come together. So the first component is the cost growth benchmark, which is applicable for all payers and populations for 2021 and 2025. OHS is collecting data from payers on an annual basis to assess how fast healthcare spending is growing year over year, and comparing that to a benchmark that was developed by OHS's technical team. So for 2021, that benchmark value is 3.4%, and it goes to as low as 2.9% from 2023 to 2025. The second component is the primary care spend target, which is kind of a parallel initiative to the cost growth target. Executive Order 5 states that primary care spending as a percentage of total healthcare spending should reach 10% by 2025. And once again, this is applicable to all payers and all populations. So OHS is monitoring primary care spend as a percentage of total healthcare spend using data collected from the Cost Growth Benchmark Initiative. And so far, OHS has only set a benchmark of 3.4% in 2021. That was our best guess estimate of where primary care spending was at the time that we set the 2021 target. And OHS has another advisory body that is setting interim annual targets from 2022 until 2025. The third initiative is a data use strategy. So this is a complementary strategy to both the cost growth benchmark and the primary care spend target that assesses data from the APCD as well as some other complementary data sources to really take a deeper dive into assessing where are costs high and where are cost growth high. And this will help OHS as well as payers and providers in the state kind of target which areas of spending might be the best bang for our buck in terms of meeting the cost growth benchmark. So this is looking at spending by spending category, by individual health systems, by geography, really slicing and dicing the data in a number of different ways so that we can identify our best opportunities moving forward. And finally, the fourth component, the quality benchmarks, this was really the state's effort to make sure that while we are trying to control healthcare spending, We want to ensure that we are also improving quality and making sure that there's no unintended negative consequence of having something like a cost growth benchmark. So the quality benchmarks are measures, as Brad mentioned, that are applicable to all public and private payers, that is effective as of 2022 and goes until 2025. And we'll get into the weeds of what the quality benchmarks entail in the coming slides.
Thank you. I just want to pause for a second to see if there's any questions or comments that anyone wants to ask or anything anyone wants to say.
Currently a muted comment, Alt+A button.
Hi, Brad. This is Donna again. I have a question on the primary care. How did we come up with a 10% total spend for primary care? I'm just ignorant of the process and don't know.
That is something I actually do not have an answer to. That was part of the executive order, and we kind of came in after the executive order was set. But I'm happy to look into that and have us get back to you on that.
Oh, thank you. And, does that include like oral health care, primary care spend, or is it just primary care for medical overall? I'm just behavioral health, I'm just curious on what it entails too as well.
So the primary care spend definition is based off of work done by the New England States Consortium. It's called NESCO. I can't remember what each letter stands for, but it takes a pretty comprehensive look at what primary care spend entails, but it does not include oral health comprehensively. It includes preventive dental services that are administered in a medical setting. And does include some integrated behavioral health services, again, when developed and delivered in a primary care setting. There is a primary care core definition, which is what is used to assess the 10% as a total percentage of total healthcare spending. But OHS is also monitoring primary care spend that is delivered by OBGYNs, as the technical team noted that many women do receive their care from, or their primary care from, OBGYNs. So it's not as comprehensive on the oral health care front, but does take a deeper dive into OBGYN versus a quote unquote traditional primary care provider.
Thank you.
Kelly?
Yeah, hi, I was just wondering, so what is the current percentage of primary care spend?
So our best guess estimate prior to collecting the cost growth data was 3.4%. There were a couple of studies that were done by UConn, by Friedman Healthcare, and by a number of other sources. And so we tried to piecemeal what was primary care spending for each individual market, and then use that to develop a statewide estimate. We are in the process of reviewing initial data from 2018 to 2019, that what OHS received through the cost growth benchmark. And that initial data shows that current spending is actually higher than 3.4%, which is great. But we are still combing through and validating the data before we can provide an actual percentage of where current spend is.
And so while they're doing up to 2019, will they include 2020 data with a grain of salt, so to speak, because all of the numbers are skewed, as we all know?
Yes, so we haven't collected anything beyond 2019 yet. Usually we collect data in like 1 year after the performance period to allow for sufficient claims run out and all of the wonky details associated with that. So yes, we will expect to see a dip in 2020, 2021, and likely maybe a little bit into 2022. So we will contextualize all spending. We acknowledge that it would be really hard to continue an upward trajectory from 2019 because of the pandemic, and we'll be sure to make sure that there isn't any negative messaging around what the values are, because some things were very much out of our control.
Right. Okay, thank you.
Sandy?
Yeah, I was wondering, actually, I had that same question that Kelly had, but I also was wondering, we said it covers all payers. What exactly does that mean? Does that mean like self-insured plans? And ERISA plans? Everyone is going to be subject to making these changes and these quality benchmarks?
So it's a little bit different depending on what the initiative is. For the cost growth benchmark, we do receive aggregated data from insurers. So we receive commercial fully insured and self-insured data. We receive Medicare Advantage data. We receive Medicare fee-for-service data from CMS. We receive data from DSS. We receive data from the Division of Veterans Affairs. We receive data from Department of Corrections, and we do receive data on state employees from the Office of the State Comptrollers. So it's pretty comprehensive. I think the cost growth benchmark covers the most payers out of all the initiatives. The primary care spend target includes commercial, both fully and self-insured, Medicaid through DSS, and Medicare through Medicare Advantage and from CMS. The quality benchmarks is limited to commercial, both again, fully and self-insured, Medicaid through DSS, and we are limiting Medicare to Medicare Advantage due to the challenges associated with receiving quality data at the provider level for Medicare fee-for-service.
Thank you, Deepti. Feel free, anyone else wants to chime in for questions, feel free to raise your hand. We'll keep moving forward, but if anyone wants to go back to anything, please feel free to interject.
So now delving into the quality benchmarks. The quality benchmarks are effective January 1, 2022. You may note that the cost growth target and the primary care spend target were effective in 2021. And that was to ensure that we had sufficient time to talk through the quality strategy and make sure it was as comprehensive as it could be. And so we didn't want to rush in starting all initiatives at the same time. The quality benchmarks specifically are focused on trying to maintain and improve healthcare quality. As I mentioned, it's applicable for commercial, Medicaid, and Medicare Advantage payers. And the executive order noted some potential areas that the measures could focus on, including clinical quality, over and underutilization, and patient safety measures. Connecticut is the first state to have quality benchmarks. Delaware was the first. They established their cost growth benchmark and quality benchmarks back in 2019. Ooh, excuse me. One thing I'll note here before we move to the next slide is that OHS really wanted to ensure that the quality benchmarks were focused on measures that could be applied at the payer and the provider level. When we first started delving into the types of quality benchmarks that could exist, we kind of categorized them as two different measures: health status measures, which are more higher level measures that look at population level characteristics, and that can be assessed at the state level. We started off initially in the brainstorming phase with more health status measures, but then we realized that one really important lever that OHS wanted to leverage in improving performance is looking at what actions payers and providers could take to do so. And so we ended up resulting in more healthcare measures, which are healthcare processes or outcomes that can be assessed at multiple levels, including the state level, market, insurance, and provider levels. As some of you may know, OHS has a core measure set, which is an aligned measure set that it hopes payers and providers will use in contracts. And so we lifted a lot from the core measure set when thinking about the quality benchmarks. The Quality Council first selected measures and then looked to develop a statewide target for each quality benchmark for 2025. We'll get again into the details of this, but there's a phased approach to try and reduce the burden on payers and providers. And so we're starting with a few measures in phase one that are effective beginning in 2022. And for those measures, there are interim annual targets that will allow for incremental progress to reach the 2025 target. Our general process for thinking about how to develop the quality benchmarks is as follows. We started at a high level to think about what are our guiding principles for selecting these measures. We wanted to make sure that we set our goals ahead of time before we delved into the details, because Oftentimes when you get into the weeds, you kind of forget about the purpose of why you're doing what you're doing. So we had guiding principles that we referred to frequently throughout the process. We then reviewed candidate measures and identified a handful of measures that we wanted to include for the benchmark. We then took a step back and determined at which levels each measure should be assessed. And that is where we kind of differentiate between the healthcare measures and the health status measures. We then went and looked at current performance for each measure and identified where we thought performance should be in 2025. We strove to create a balance between a benchmark value that was attainable in the next 3 years, but we also wanted to strive for improving progress. So we, and improving performance. So we tried to balance those two, what is feasible and also what should be achievable in the next 3 years. We then talked through how OHS would collect data, validate data, evaluate performance against the quality benchmark values, and publish performance. And then we ended with thinking through how to maintain the quality benchmarks over time in case there were any specification changes to the measures or any changes to the survey administration for some of the population health-based measures. As I mentioned before, we're proposing a phased approach to the quality benchmarks. This is the tentative slate of quality benchmark measures. In phase 1, which are the measures beginning in 2022, we're proposing 3 measures: asthma medication ratio, controlling high blood pressure, and HbA1c control for patients with diabetes, specifically the poor control, which looks at HbA1c levels greater than 9%. I'll note that asthma medication ratio has not been officially recommended by the Quality Council. We've been back and forth in conversations about the measure and expect to come to a final recommendation on that measure in December. The phase 2 measures will begin in 2024, and there are 4 measures here: child and adolescent well-care visits, follow-up after ED visit for mental illness, and follow-up after hospitalization for mental illness. And those last 2 measures are the 7-day rate. All of these 6 measures I've mentioned so far are part of the core measure set, and they can be measured at the advanced network level and at the payer level. We can then aggregate performance to get a market level performance and a state level rate as well. The final measure here in phase 2, obesity equity measure, this looks at the difference between the statewide obesity rate among the Connecticut white non-Hispanic population and the Black non-Hispanic population. We are using data from the BRFIS, the Behavioral Risk Factor Surveillance System survey that is administered by the CDC every year, and using that data to calculate what the gap is between those 2 race ethnicity categories. So that is a measure that we will implement in 2024 and will only be assessed at the state level. Before we get into some of the values, I wanted to pause really quickly and see if there's any questions about these measures or the process so far. Karen.
Hi, yeah, I have been following the Quality Council on and off, and I'm surprised that there aren't more equity measures included, and particularly that the obesity equity measure is restricted to 2 categories, and particularly 2 that may not provide useful information given the high percentage of Connecticut's Black population that also identifies as Hispanic. So I'm just not sure when those decisions got made and why there isn't more effort to include at a minimum data completeness and ideally more of the equity measures that were discussed by the Quality Council.
So I want to make a distinction here between the quality benchmarks and the core measure set. So OHS is deeply invested in looking at more equity measures in its core measure set. We are looking into a health equity measure as part of the core measure set, which takes measures from the core measure set and stratifies performance by race and ethnicity. We are revisiting the core measure set in 2022, and we'll consider a data completeness measure as part of that process, as well as additional health equity measures. The quality benchmarks, we are limited here by data that are available and data that are, I don't want to say clean, I think that's the wrong word, but we wanted to set a benchmark for 2025. And as of right now, we did not have data available to us to identify at the payer and provider level what are performance on these measures stratified by race and ethnicity, and what is data, how complete are data at the payer and provider level. Because this is a statewide initiative that requires data from multiple sources and kind of in a standardized way, we couldn't enact that at the time, with the time constraints that we had. We had to have the benchmarks effective before 2022 so that they could actually go into effect in 2022. So we agree, there's not necessarily, we wish there was more we could do on the quality benchmark front, but we are pursuing this in the core measure set. And if the quality benchmarks are extended beyond 2025, I think we will have more opportunity to add more equity measures into the quality benchmarks at that time. The obesity equity measure, that too was limited by what data were available through the BRFIS, the Risk Factor Surveillance System Survey, and the white, non-Hispanic, Black, non-Hispanic categories for the defaults that they had. And they were the race ethnicity categories that had the greatest gap in 2019. And so that's why we prioritized that. We also, and this is my last point, we wanted to make sure that we had a number of quality benchmarks that were broad in scope, that we were covering a lot of different topics, but also narrow enough that we could actually make incremental progress between now and 2025. We were initially looking at a slate of, I think, anywhere between 10 to 15 quality benchmarks. And when we thought about the resources available and the time available to actually meaningfully improve performance on a state basis, we wanted to make sure that we were limiting the universe and then expanding in the future once we've got this under our belt.
Sandy?
So in looking at the phase 1 measures, is there a reason there were really no pediatric preventive care measures included there? Certainly there's kids with asthma, but there doesn't seem to be much in the way of pediatric.
Yes. So 2 points on that. To what you had just mentioned, the asthma medication ratio, we're proposing to have 2 separate benchmarks, one that's focused on a pediatric population ages 5 to 18, and another focused on the adult population 19 to 64. So there is a pediatric focus there. We initially wanted to have child and adolescent well care visits in phase 1 for the point that you just mentioned, to have a pediatric preventive measure in the phase 1. Except this is a relatively new HEDIS measure. It was adopted, I think, in 2020. So there are no national benchmark data available against which we could compare performance that was not severely impacted by COVID. So this was more of a data limitation issue where we did not know what good performance was. NCQA did combine 2 former measures, one focused on well care visits for children and one for adolescents, but they indicated that we couldn't compare performance for those 2 measures with this new child and adolescent well care visit measure. So this was more of a data limitation issue. We wish we could have added it for phase 1, but we had to move it to phase 2 reluctantly.
So, and couldn't do anything like, developmental screening or anything that's really meaningful, because even, child and adolescent well care visits, it's pretty low hanging fruit and pretty, you can go to a walk-in place and that can get checked off when it's really not true comprehensive well child care.
Yes. So developmental screening was one of the measures that we considered. We were looking at a number of factors when selecting the benchmarks, and one of them were measures that were in use by payers and providers in the Medicaid and commercial markets already. And that would provide us with a greater data reporting rate because we're asking payers to submit data by provider entity to OHS on these measures. And we found that more payers were using child and adolescent welfare visits and developmental screening in their contracts. And so we thought that we would get more information from child and adolescent welfare visits rather than developmental screening. It also covers a wider range. So developmental screening, while more complete, is only from ages 0 to 3, whereas child and adolescent welfare visits goes until 21.
No, actually, our kid will develop, screening goes all the way up through college.
Yes,
not the infant screening, obviously, but we do developmental and behavioral health screening all the way through college age.
Yeah, the measure that's included in the Medicaid core sets, I think, is only focused on ages 0 to 3. So that's what we were looking at.
Okay, thank you.
Mark?
Currently, a muted comment. Alt + A button.
I'm hoping it's possible to age adjust or age stratify the equity measure on any measures that have race, ethnicity as a component, given that the age is the primary driver of differences observed in some of these indicators.
So I'm thinking back to the BRFIS data. We may be able to stratify that by age. I have to double check to see what the data source provides. For the other measures, asthma medication ratio is stratified by age. We're focusing on pediatric and adult separately. The rest of the measures, with the exception of, yes, I think the rest of the measures are mostly reported at a total aggregate. We are considering whether or not we can use data from the statewide health information exchange, CONI, in the future. And if that is a viable data source, we're open to being able to stratify these measures by a number of other factors, including race and ethnicity, and we can explore age. But that's really dependent on the viability of the data source and whether it will be robust enough for us to rely on. So that is a long-term strategy. We're hoping it's effective by phase 2. But we'll have to revisit that on an annual basis.
Yeah. The obesity equity measure, definitely, if it's BRFSS based, we should be able to calculate age adjusted rates. So those are important as you go from like people in their 50s, 60s. And if you don't do that, it may show, for example, with COVID, that was the main example where Hispanics had a much lower risk rate than whites, but that was entirely due to the age differences in population.
Thank you for that. Yeah, I'll take that back to OHS and the Quality Council.
May I ask a question? I'm unable to raise my hand. This is Donna. Is it possible to put an oral health measure in for each PCP? For example, if you look at the PCP and if the child or adult or teenager, any one of those groups, because all the 3 groups should be measured, are getting oral health services, and if they're being advised to get oral health services, I think that's pretty much an easy one to do. An easy measure without, a heavy lift. And eventually,
keep going.
And eventually add something a little bit more salient in the future where we can actually look at maybe quality from the dental provider point of view. I've been thinking about this one for a little bit, for a while, based on what value-based payments, there was a methodology we were coming up to use that. But if we have somebody in, say, a primary dental office and they're getting continual care and they're not developing caries, they're in better shape than someone is who's developing caries. And we know they're getting the nutritional counseling and dietary counseling, about what causes tooth decay and things like that. And they're getting the appropriate treatments like fluorides and MI pastes and things like that. So that's something that we can work on to add in the future, but at least as a minimal, put an oral health measure in for the attributed primary care practice and how many or what percentage of patients are actually getting primary dental care.
So that was, oral health was a focus of where the Quality Council wanted to, what the Quality Council wanted to include in its quality benchmarks when we first set out on this endeavor. We did run into the data limitations again. So the quality benchmarks are intended to be applied across markets, so commercial, Medicaid, and Medicare. We
Yep.
did have robust data on the Medicaid front and
Yep.
did have national data against which we could compare to set what the 2025 benchmark value would be. But
Yep.
we were unable to find similar information on the commercial side and on the Medicare side. So we ran into issues where we could either have a statewide rate that couldn't be further disaggregated into a payer level measure, market level measure, or a provider level measure, and we couldn't set benchmarks. So
Well,
we
I
initially,
think, okay, I'm sorry.
we also didn't have data from oral health providers that we could leverage to then look at Medicaid versus commercial. And so that was another limitation. We were limited
That
really
one,
to
yes.
medical data.
Spend that one, that's why I said that we can work it in a phase 2. But for phase 1, we can at least look at who's getting services and not. And, you know, if we don't have it for commercial, or if we don't have it for Medicare, Medicare doesn't offer dental benefits. And we all know that it didn't make it through this session. It's still on the table to make adult Medicaid benefits a non-optional service for, you know, oral health. So that's still on the table and could happen. So I think it would still be very valuable. So you're comparing Medicaid population to Medicaid population. That's not a bad idea. And if you don't have anything available in commercial, that's something that I guess the national folks could look at developing in the future. At least we could be the groundbreaking people for that. Just because it doesn't exist doesn't mean we shouldn't do it. That's my philosophy on this.
Right. Yeah, we wanted to try and stray away from measures that were market specific. So that was part of the limitation for not including it in the quality benchmarks. That being said, there are still several gaps in the core measure set, and oral health has been identified by the Quality Council as a gap in the core measure set a few times. So similar to thinking about health equity measures for the core measure set for 2022, oral health is also at the top of the Quality Council's list. And so I do think we'll probably be able to make some progress on that front when we reconvene in 2022. And hopefully that can make its way into the quality benchmarks, perhaps for phase 2 or for if the benchmarks are extended beyond 2025.
Yeah, well, I worry out of sight, out of mind is what happens, you know, especially now. And I think it's very important to portray what good work has been done with kids who've been brought up in the program. I was just reviewing data this morning with Bill Halsey about the lack of need for dental treatment for children because they've grown up in the program with good oral health, hygiene, and reinforcement of good habits and regular dental care. So our original hypothesis was if you bring kids up in the program, you know, with good oral hygiene and practices and et cetera, they're not going to need the expensive treatment. And that's, you know, what our 14-year experiment has borne out and proven. So, I mean, it would be good to show it for adults and everybody else.
Thanks, Donna. I think just for purposes of our quality council component, we're kind of, our task will be mostly to, you know, review the recommendations, though I think your point's well taken.
So now moving on to the actual benchmark values. So for 2022, the OHS and the Quality Council recognize that we are still setting benchmark values roughly 1 month before the start of the measurement year. And so that doesn't leave enough time really to begin any interventions to improve performance on these specific measures. So OHS and the Quality Council recommended keeping 2022 benchmark values the same as the baseline rate, and we used 2019 as the baseline rate. So that is applicable for all markets, and we wanted to show you what the benchmark values would be for Medicaid if we adopted that. So here are the phase 1 measures, asthma medication ratio that, again, split by age. So pediatric ages 5 to 18, and then adult ages 19 to 64. The 2019 Medicaid rate, which is the proposed 2022 benchmark, is 66% for the pediatric population and 63% for the adult population. As you can see, we included where Connecticut ranks relative to national percentiles. This is relative to national Medicaid percentiles, just for reference of where Connecticut stands. For controlling high blood pressure, current performance is 61%. So that is the proposed 2022 benchmark. And HbA1c poor control, this is a measure where a lower rate indicates better performance, and current performance is 37% for the Medicaid population. So this is a snapshot of what the proposed benchmark values would be for Medicaid. Again, these are not final. The Quality Council has not reviewed asthma medication ratio and has not yet taken a step back to look at all of the quality benchmarks in full. So they will be doing that in December, and then we'll bring that to you for your full recommendations in December.
Any questions on this? We can come back. Again, we'll be revisiting this. So appreciate everyone's engagement and questions. I think it's just good for everyone on this to be aware of these efforts. And I sit as the DSS representative on the Quality Council. So am fairly well abreast of this and appreciate it. Thank you for going through this. Very helpful, and appreciate your time and effort here. And I suspect we'll be seeing you again, or at least Kelly, one of the two of you.
Yes. Thank you everyone for your feedback too. We will bring this back to OHS and the Quality Council. So we appreciate your preliminary feedback.
Thank you. So, for the remainder of our time, just wanted to kind of have next steps in an open discussion that would be helpful. So we have a meeting, and I had just pulled it up, and now I think it's the 15th. Is that right, Susan? I looked at it, and now I think, or is it the 14th? Regardless, in approximately a few weeks, we have a follow-up meeting already on the books, and
I think it's the 17th.
17th, thank you. Thank you, Meg. Yes, there it is. I found it in my calendar. I had found it before, and then I don't know where it went. We're hoping to have a demonstration of a little bit more of a live dashboard rather than just a draft. That's our internal goal, to present to you, that we have something that's presentable. Again, it's probably going to be limited what the data set actually is at that time, but something that drives us towards what we're hoping for, and something that we can really display to you at that time for feedback and follow-up and questions. The other piece will be reviewing kind of what we were just discussing a little bit further at the next OHS quality benchmark. After their follow-up, we may need to revisit this again in January as part of our conversation. But again, I think it is useful for us to stay abreast of this. There is obviously some intersections between these two components of the DSS transparency and the OHS work in general regarding EO5 and EO6. And then one other thing I wanted to raise for a possibility, as Susan and I have been reviewing and working with our ASO partners, they are producing dashboards, most of them, that we potentially could review here, that may be for more just for knowledge, so that everyone here on the council is aware of what's currently being produced by the ASO vendors or contractors, and also provide you more insight into what may be things that we might want to produce in the future. So also for some idea generation. But I wanted to propose that and get feedback if others think that would be helpful. We could do it over a series of several months, basically, and not ask them to present for hours, but maybe like a half an hour overview of some highlights of the kind of dashboarding and quality data that's currently produced, but just not currently publicly available. Thoughts on that?
Hi, Brian. That sounds like a good idea.
I agree.
Karen?
Yeah, I agree. I'm always impressed by what the ASOs present at MAPOC and BPOC, and it seems like there's a lot of really good, useful information there that could be incorporated into this project.
Okay. I see a thumbs up from Ben as well. Thanks, Mag. Sorry for your comment. Any other thoughts, concerns? So I think process steps is I'm going to ask to get continue to have meetings on the books. I know we'd kind of canceled the last one, but I'd like to get make sure we have a monthly meeting scheduled for this group, and then start scheduling the ASOs to come and ask each to, again, individually present kind of a 30 minutes highlight of their dashboarding work as it currently stands. Probably either starting in January, February, depending on what we can schedule and what who's going to be available. And then in the interim, I think Susan and I will be meeting internally to move some of this work forward, and hopefully, again, at the next meeting, we'll actually be able to present you with something that's close to something that can be live at that time. Susan, any other thoughts? Any other thing you want to add?
No, I think you've well identified some of the next steps. So thank you for that.
Any other things that anyone would like to bring up in general related to anything that was discussed today or not discussed today, process steps, anything at all? Just want to make sure to open it up for anyone's feedback or comments. Well, I just wanted to say thank you again for your guys' engagement, for being here, for helping think through this work with us, and I look forward to continue to engage. I mean, and we're very fortunate to have all of you and your expertise here. And I know you guys all you represent various, have various backgrounds, interests, and all of that is extremely valuable as we move this work forward. So thank you. Thank you. All right, so we'll adjourn and see you guys in approximately just over 2 weeks, and we'll follow up on some of the things we discussed today. So thank you, and look out for some scheduling for the future as well. Thanks, everybody.
Thank you.